In our hospital, which is a women's hospital, we deliver about 8,500 women. And being in Louisiana, we have about a 14% gestational diabetes rate. So we have over 1,300 women that have gestational diabetes. In previous work that my collaborator and I worked on, we found if we followed these women postpartum, about 5% postpartum, actually the diabetes doesn't go away. And in the rest of them, there's about 20% that have what we call glucose impairment, and then about 80% that still have some defect in their insulin and glucose, which is why they got gestational diabetes. Although, once the pregnancy hormones are gone, it tends to go away. However, in that group of women, if we followed them over a year, we found that about anywhere from 25 to 50% actually got worse and or converted to diabetes in that first year. Okay, so given that, and we tried to do some kind of intervention in terms of diet and exercise, which is always the first line recommendation. But as one can imagine, when you have a newborn, the chance of your life has already changed significantly, and to sort of throw this on top of that is virtually impossible. So we look to use medical intervention, using anti-diabetes medications, basically to prevent beta cell deterioration. Given the new medications that we were familiar with, we perceived that things like the new DPP-4 inhibitors might even be more efficacious, and particularly if they were combined with metformin. And given that that is a single pill, it would again be very easy to see its efficacy. So we conducted a study where it was simply a 16-week trial, very short. These were women who already showed glucose impairment. So, they're going the wrong way, as we kind of say. And they were randomized to either receiving a placebo pill, metformin, or the combination of metformin and a DPP-4. And where it was a single-blind study, the patients knew what they were taking. However, the investigators were blinded until the study was completed. So that was the sort of the initial goal of the study. In the combination, what's really nice is we're going to use the same dosage of metformin that we use. And that's the way they were designed, so that they're usually like, if I remember, I know it's 1,000 mg of the metformin, sometimes extended release, but in terms of the dosage, they have titrated it so you get as if you were taking a single pill of the DPP-4. They do it twice a day, so that you can kind of gradually increase like you do with your metformin. So we use the maximum dose, mainly to see, if you're looking at an efficacy, you want to kind of hit them with the highest, and then you can always back down if need be. But it's taking 2 pills we figured would not be too difficult for this patient population to at least be compliant over that period of time. Now, one of the things that was sort of our selling point for this was every single one of those patients received a personalized diet and exercise program from our dietitian, who most of them had worked with before when they were pregnant and had done so it kind of was a nice continuity of care, which is what we try to provide. So they were very happy to go see her again. But I think that time of having that really is helpful, because she was trying to fit their changes into their lifestyle, so it was very personalized. Unfortunately, in the group that didn't get medication, even doing that, we had a very, very small percentage that actually showed improvement in the 16 weeks after we looked at them. And in fact, one of the caveats is in our clinic, which is what we do, most of those patients were then put on medication after the 16 weeks. And that was part of the reason we did it for a short interval, because if we didn't see improvement from a medical standpoint, we didn't want to leave these patients becoming diabetic while they were under the study, because many of them were close when we first evaluated them. The most exciting, of course, is that with the combination group, we had 75% of the patients become totally normal, okay? And in ones that didn't become totally normal, so this was kind of a mixed group. You could be impaired fasting, impaired glucose tolerant, or a combination. And so in the ones that were combination, let's say their glucose tolerance part improved, but their fasting might still be a little elevated, but they still improved significantly. In the metformin group, we had about a 40% improvement, which is pretty much what's out there. And so there were some patients that is they don't need the combination. In the placebo group, we're getting the final numbers, but it keeps, we have about 3 or 4 of the patients becoming better, so it's maybe 20%. And that's in that short window of time. But to see them convert was just impressive, really impressive. And very, reinforcing. One of the things with this patient population, and most patients, you want to see results right away. And the fact that they were normal also makes them more compliant to stay at least with this until they lose that baby weight and kind of, have a chance for their pancreas to kind of get back to normal. One thing we stress is that postpartum, you really need to test these patients, not just with a fasting glucose or A1C. They need a 2-hour glucose tolerance test because so much of this doesn't show up unless we get the 2-hour test and really get to look. One of the things we do in our practice is we also look at insulin, the pattern of secretion, and the reason that's key is somebody's sugars might all look the same, and one of them's hypersecreting insulin and one is just barely squeaking by. So, it gives you an idea of what kind of intervention do I need to use. My biggest take home is gestational diabetes does not go away after pregnancy, okay? I hear that again and again, and it doesn't. I mean, the gestational diabetes, but the reason you got it and your risk for diabetes actually goes up.